We have a question from the audience. Linda writes, I've heard that CLL doesn't need to be treated right away. Is that true?
So that is true for the majority of CLL patients, and it's actually a very counterintuitive thing. So we're kind of conditioned that if you have cancer, that it's important to be proactive and get rid of it as quickly as possible. The sooner the better, and that is actually not the case in CLL. And we didn't just take a guess that that's the best approach. This is actually something that's been studied in clinical trials. So there were several clinical trials launched in the 70s and 80s looking at an early intervention strategy using a chemotherapy-based approach to see if treating at the time of diagnosis would be better than waiting until patients developed more significant symptoms. And all of those studies did not show a benefit to early intervention. Now, more recently, those studies have been challenged as somewhat out of date, which is a fair criticism because they used an older chemotherapy drug. And so there is a newer study now going on in Europe that is looking at early intervention with the drug ibrutinib, which is one of our novel agents for CLL, looking to see if early intervention with ibrutinib, particularly for patients who have a higher risk form of CLL, may be beneficial. But we have seen some data now already presented from this study that do not show any improvement in how long the patients live by treating with ibrutinib early. And we do see some of the typical side effects that we're accustomed to seeing with ibrutinib. So even with the newer data that we're seeing, we still do not recommend early intervention for patients with CLL.
I've heard this term watch and wait. What does that mean?
Yeah, so it's not the best term because it's very passive. So that refers to this observation strategy. I like to think of it more as active surveillance. Seems more proactive because you're doing something about it. You're really kind of checking the blood counts. You're getting your physical exam. You're checking in on symptoms, these sorts of things, and really keeping a close eye on the disease. And that's the approach that we like to take with our patients to really keep them engaged, making sure they're staying up to date on their screenings for other cancers, making sure they're getting vaccinations. These sorts of things are all the things we do with active surveillance.
How is someone monitored during this watch and wait period?
So it varies depending on individual patients. We've alluded to the fact that there's different genetic subgroups of CLL already. So there are some patients who have higher risk disease. The example of that usually is deletion 17p that people may have heard of on the FISH test. So for those patients, I usually am seeing them every 3 months or so, physical exam, checking on their history, checking their blood work. But there's quite a few CLL patients who have lower risk disease. And, if they have, for example, mutated IGHV is one example. If they do not have the 17p, for example, those patients may be able to be seen once every 6 months or so with a similar setup. I don't routinely get CAT scans on a regular basis for most patients. Most patients don't need bone marrow biopsy tests unless they're starting treatment. So mostly it's exam, talking to patients, and checking the blood work.